Hello, 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 folks. We're going to give people a few more minutes to get started and get here into the room. So welcome, welcome. In the comments, if you would like to, you can drop a little information. Just let me know who you are, what brought you here, how many of our webinars have you been able to watch. This is the finale, okay? That means we've had three other webinars up to this point, great. We started, if you've been here from the beginning, then you know we started with just general pelvic floor, trans health related, that got complicated, terminology, pronouns, terms, just introducing you to hormones, pre and post-op, and then what pelvic health might look like related to that. And then we went into pre-op, where we dove a little bit more into hormones, and we dove a little bit more into binding and tucking and things like that. And then we took a small, shift, and we went into caregivers, because it's not just that we want to be able to provide care for our trans, non-binary, and gender diverse people, but we also want to make sure that the people who are providing that care, right, are taken care of, or know that there are support groups and people out there who they're not alone in this whole process. And then, of course, we end here with our post-op recovery. Okay, so we're gonna go through, well, I have a table of contents because I love my table of contents, but we're gonna go through a little bit of what different type of surgeries look like, what healing, wound healing, right? Scar massage. I am going to hit so much on scar massage, it's ridiculous. And then, of course, some exercises, because I am a movement specialist. That's my job. And then, leaving you with answering any questions that you have, leaving you with some resources. And yeah, so hey, I've talked a lot. Folks should be in the room. If you're not in the room yet, you're going to catch this part on the replay. Okay? Because there's a replay, as always. Let's see. Now, you know that I'm not great with technology at this point. So is my computer is it gonna work with me today? Let's see. But welcome to pelvic health, physical therapy, trans pelvic health, physical therapy, post-op recovery. All right. Here's right. So a little introduction on myself. Going into some surgical procedures, I'm going to talk heavy in this section. I want to keep things under like an hour and 15 minutes. I talk a lot, that's okay. But there's so many different procedures and ways that affirming care can be provided, that having the language can be so helpful. I'm gonna go into it. Wound healing, what does that look like, right? Scar massage, okay? I'm gonna hit that heavy. Why? Because honestly, scar massage can really determine how you function, how you heal, how you get back to your normal activities, what that even looks like. So scar massage is a big, big part of healing, okay? And then exercise and normal activity, of course, right? How are you gonna get back into, like, are you a runner? Are you someone who has a job that requires a lot of lifting? Those are things that you want to get back into your normal activity. How do you even do that? All right. So let's see. Oh, my disclaimers. Okay, I love them. I do love my disclaimers. So this information is not medical advice. Okay. While I am a doctor of physical therapy, while I can provide medical advice, I am not your doctor. And so this information is purely for educational purposes. So if any of it is like, hey, I have this question, or I think this might apply to me, please consult your medical provider for specific recommendations and advice for you. If I am that medical provider, unless we talked about this stuff, don't go out and do it. Okay. Just one of very many disclaimers that I'm going to put out there. Okay. So it's me. I am Dr. Sha'Rose Arian. I am a pelvic floor physiotherapist, which is another way of saying physical therapist for my folks here in the US. So I am a physiotherapist through my training through theory. The University of St. Augustine that I went to in Austin, Texas, is a Australian, New Zealand theory mechanism and method curriculum based program. And I also did a 2-month internship in Australia with a physiotherapist one-on-one. So when I say I just kind of look at the holistic part of a person, it's because that's the only way that I've known how to do physical therapy and physiotherapy. I'm your pelvic ally because honestly, I take care of everything: hips, back, abdomen, chest, your whole body. And I'm an ally to you because anything that goes around your pelvis, I want to help and make sure that it's functioning properly, it's functioning the way you want it to, and how it should, and giving you the pleasure and joy that you deserve. Right? I am owner of Rose Pelvic Physiotherapy, where I practice as well. And honestly, I just truly created this space for folks to be able to find somewhere safe, affirming, and inclusive, that you can get good information and education on your body and what's happening in treatment without it being, scary. And that's what I've created with Rose Pelvic Physiotherapy, located in downtown Huntsville, Alabama. I'm a mom of two, which you might hear them in the background because, hey, they're home. We're both home. We're all home. And I am a wife to my lovely husband who is taking care of those children right now. I am a bisexual woman and love one of a transgender person. So when I bring all of this information together, when I put together these webinars, I'm not only speaking from my, personal experiences, which I do have many of. I'm also speaking from my clinical experience as well as my educational experience. So I bring all that together to put this information here for all of you, and then myself, right? Because, staying up to date on this information to create it for you. That is a little bit of who I am. Please, if you feel comfortable, share who you are or what brought you here, even if that's in a private message. I read all of it, I promise. But yes, a little bit of who I am. Now, let's get into some surgical procedures because that is really what y'all came for. It's okay. I know I'm cool or whatever, but I know what's up. Another disclaimer here, with the surgical procedures, there are just entirely so many different ways that any of these can look. So if you've been here, you've seen this graphic that's coming up. You've seen it multiple times, and that's okay. But we're going to break down each one way more than we have in the past. And that way you can really get a good idea of what we're talking about and the different things. And frankly, sometimes I just want to make sure you have a language. Okay. I just want to make sure you understand when someone says bottom surgery and they say vaginoplasty, what do they mean? And we start pulling out some of these words. So all that to say, this is not all inclusive at all. It's just a small percentage of surgeries that folks may consider. Also, one other disclaimer, I know I love them, is that there is no right or wrong way to be trans, non-binary, gender diverse. There is no one way. So surgeries are not always something that a transgender person may want. Any or all of these. These are not a step-by-step process that you need to do this in order to do this in order to do this. Some folks may only do bottom surgery. Some folks may only do top surgery, right? So just being clear that this isn't inclusive of all trans folks' experience, but some people fall into these categories, okay? So again, here's that graphic, right? Language that I'm using, female to male, male to female. Also, I might throw in there feminizing and masculinizing, masculine, as well. My language is what I use. If it is offensive or you're uncomfortable with it, please share that. I'm open to all discussions. But all right, we're going to talk about, starting on the left, my left, hopefully yours too, but chest reconstruction or chest masculinization surgery. So this is what can sometimes be considered top surgery, right? So this is the removal of chest or breast tissue, okay? Now, it can be that, right? So this process, that removal of chest tissue, is when we're talking about surgeries and we're talking specifically about any type of requirements for surgery, we do have to mention that because every state, unfortunately, is different and your insurance can be different. The WPATH has their standards of care, okay, which is what globally, right? WPATH is the world. So they put together the standards of care for transgender health. And based off of their recommendations is usually how insurances in some states base their requirements for whether they cover any type of surgeries or not. However, the standards of care, which I believe 8 was the most recent one that came out last year. It came out last year. So a lot of these requirements haven't been updated yet. So when looking at this, things like letters from a psychologist or psychiatrist may be required. You may need to get surgeries in order to change your marker on your birth certificate, or to change your marker on your ID, right? So unfortunately, some states, Alabama is one of them, have laws where you actually have to get one of these surgeries in order to change, say, from male to female on your identifications, which doesn't seem like a huge deal unless you get pulled over or you're trying to go to a bar or something and you present one way, however your marker says another way. It makes things pretty uncomfortable. So all that to say, sometimes surgeries unfortunately are necessary in order to kind of change some of the things on documents. But anyway, so chest reconstruction, removal of that breast or chest tissue. With that, what happens is the surgeon goes in and they usually do it in, like, you see some like C-shaped underneath the where the pec muscles would be. And so you get these C-shaped into the armpits, right? And sometimes they get it right? Sometimes they get it great. The placement of that scar is right underneath those pecs. You do some lifting, you develop those pec muscles, and you're able to kind of hide those scars under there, or hair continues to grow, something like that. Sometimes they're not great, and the placement of it might be a little too high or a little too low. Okay. Now, there are a few different ways. So there's like a keyhole way that tissue can be removed. There's also just more like an open flap where tissue can be removed. And you have the option of nipple versus no nipple. Some people don't want nipple. Some people don't want areola. And some people also want an exaggerated kind of like C-shaped scar as well. So this is where there's no judgment on how folks want to present or affirm their own bodies, and some surgeons will comply with that and some will not. So being very, very aware of what type of procedure and type of protocols and methods that your surgeon uses becomes really important. They really can vary from surgeon to surgeon. Even in the same facility, it can vary. So if you have an idea of what you want your body to look like and you've seen pictures, making sure that that surgeon was one who was able to get that result is super important, because you don't want to, go in saying, yes, I would love, chest surgery, and then come out with a result that is a little bit different than what you expected just based off of their technique. And then there is chest masculinizing surgery, right? So that's where we could actually kind of sculpt a little bit and help to make a more masculine masculine appearing chest, right? Now, with any of these recovery, and we'll get into recovery just a little bit, but with chest surgeries in general, you have to be a little bit careful. We don't want to put too much stretch or strain on things post-op, because lifting our arms and stuff like that. There are some surgeons who prefer for people to stay immobile for a matter of weeks. There are some surgeons who are like, nope, we want to get you moving at, very little range of motion, very little, starting at a couple days or a few days. It really depends on the surgeon's protocol. From a physical therapy standpoint, early movement is always going to be better. And that's just, we know from other surgeries, we know from tissue healing, we know from just quality of range of motion later on, that early movement is always going to be better. And it doesn't have to be like putting your arm all the way over your head, but we do know that slight movements, also to help with things like lymphedema, to help with blood clots, all of that. We know that movement is something that is necessary early on. Okay, drop any questions bloop, 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 that you have on chest reconstruction or masculinizing surgery for me. Now, hysterectomy. This one can be, some folks see it as like step one or phase one into bottom surgery. Folks can have a hysterectomy and just kind of stop there. Folks cannot have a hysterectomy at all and be perfectly fine and still identify as transgender. But a hysterectomy is the removal of the uterus, and that can be with or without oophorectomy, which is the ovaries. So what it looks like is the uterus is removed completely. Cervix, right? So we think of the uterus, there's a cervix on the end. That is completely removed, okay? That also is going to affect hormones, right? Because we have a lot of estrogen that flows and kind of pumps through ovaries and uterus. So that's going to affect hormone balance, which may be folks' goal. So if they don't want to have that fight between estrogen, testosterone, and that balance, removing the uterus and ovaries may be the solution there. However, what that looks like, things to consider with this is fertility is one of them. With the removal of the uterus, carrying biological children, that option is removed. But if you have the ovaries, you can still do different processes for like IVF in order to have biological children. Now, when you remove the ovaries, you remove that ability to have biological children, which might not be a concern for some people. Like I said, I got 2 of them. You know what? It is what it is. So, but with hysterectomy, what that looks like is it is the most common gynecological surgery. Okay, hysterectomies are performed very, very often, all the time, every year. And so with that, it is one that is well noted, right? So with the hysterectomy, you are going to have to do a bowel prep, right? So that means you have to get everything empty out of your bowels. If you've ever had a colonoscopy, it's very similar. But with this, you just want to make sure, because it's so close to the bowels, so close to your rectum, that they want to make sure the risk of puncturing your rectum is very low. So with the hysterectomy, understand that even though it is a very common procedure, you do have to do a bowel prep for it. And other things with this, recovery is typically pretty easy. You're gonna be down for like 1 to 2 weeks. I think usually it's like 4 to 6 weeks of before you kind of get back into normal-ish activity. From a physical therapy standpoint, you 100% want to have seen a pelvic floor physical therapist prior to surgery. And if that's not possible, for sure after surgery. So trying to get back to those normal things like knowing when can I lift a certain weight, right? Those are things that pelvic floor physical therapy can help with. Hysterectomy can be done laparoscopically. Typically, right now, that's how it's done. However, it can be done through the vaginal canal as well. It just depends on what may be appropriate for your body, your anatomy, and the surgeon that you have. Okay, metoidoplasty, also known as meta, is it can vary, right? So that is one form of bottom surgery. So Meta is really just think of the clitoris, right? So you're removing the hood, so that tissue that is over the clitoris, and allowing that to be lengthened to create a phallus or a penis naturally, right? There's no donor sites that's going to be there. They're not necessarily, and you're going to be with the anatomy that you have, but just kind of lengthening it a little bit more there. So you're releasing that clitoral hood. You're cutting those suspensory ligaments and allowing for whatever length to extend there. Now, through hormones, there might have already been some clitoral growth, right? Some anatomy growth there. So you may already have some length that is present, and this is going to extend whatever may be there. Now, keeping in mind, what we're used to seeing, right, is can be anywhere from 3 to 8 centimeters, which is about 1.5 to 2 inches. So you're not going to get the girth of, say, a phallus, but you may get a little bit more length than you had before. This procedure can be overnight, right? If you're not doing any other, this procedure can be outpatient if you're not doing any other kind of urethral type of procedures. Now, you could also do urethral lengthening, which is taking the urethra and lengthening it out to the base of the now longer phallus. So with that, you might be in there overnight. Okay, this can be done. It can be done with other procedures like scrotoplasty, right? So that is the creation of a scrotum, and they implant the implants into the labial tissues, right? So that meta and scrotoplasty can be done at the same time. And so if you have something like that, that's going to be more of an overnight stay versus an outpatient type of procedure. Some people use this as a stage 1 into any further bottom surgery. Some people stop right there, and that is perfectly okay, and the affirming care that they deserve and need. And then some people start there and think they're going to stop there and decide that they're going to go further into other bottom surgery. So it can be and look a whole lot of different ways. And the best thing you have in place is that with having done a meta first, if you decide to go further into any other surgeries, you have that ability to heal a bit more before you go into anything more invasive, which, some, when we get a little bit lower and talk about phalloplasty, some surgeons do multi-stage phalloplasties, but some do single stage also. Now, healing is going to be a big part of that depending on how you stage things. But for meta, it's not necessarily a stage 1 into, bottom surgery, but it doesn't hurt if that's how things end up being also. Okay, so with phalloplasty, right? Now, this is where things can truly get, I guess I've said that all over the place, but you really can have a bunch of different options. So when you are looking at phalloplasty, that is the creation of a phallus, of a penis. When you're looking at phalloplasty, you really want to make sure that you are looking at your surgeon's techniques, their protocols, and really how they do things, right? If you have an in your mind how you would like to do stuff, making sure you find someone who aligns with that is super important. So for phalloplasty, you have the options of being able to do donor sites, right? So there is the radial forearm, there is the interlateral thigh, there is abdominal, there is the latissimus dorsi, so that's kind of the back flap area. Each of them have their own pros and cons, which honestly, that could be a whole webinar in itself. Don't tempt me. But it really could, because each of them have their own pros and cons, in the sense of like sensation is going to be one of the biggest concerns, because understanding that nerve hookups and blood flow and things like that. So knowing what is your priority, right? Do you want a larger size phallus and girth and things like that? Well, then maybe the anterior lateral thigh is more appropriate. Are you more concerned with sensation? That might be the same case for you. Are you more concerned with discretion and donor site healing and down the road? Because then maybe the forearm is a little bit more appropriate, depending on the type of lifestyle you have, or maybe the thigh or abdomen or the back. So each of them come with their own type of discretion, right? You can either, like I said before, it can be staged. So it can be staged as in all of this is done in one stage. Typically, surgeons aren't going to do a hysterectomy with they're not going to do a hysterectomy and like phalloplasty or meta. Hysterectomy does generally need to be done before anything else, bottom surgery concerning. Now, but they will do like urethral lengthening, they will do vaginectomy. Okay. So vaginectomy can look a few ways. That can be the complete removal of the vaginal canal and then kind of suturing up that space that no longer exists. Excuse me. And then now you have space for the just kind of close up perineum space. They could also do where they burn, kind of get rid of the lining of the vaginal canal. And so all the mucosa and things like that is just kind of, those layers are removed. The canal is technically still there, but they just kind of suture it up as well. So there's a couple options, and knowing, right? Making sure that because when you get your surgery, you'll get, they'll go through everything and they'll have all these words. It'll say phalloplasty with vaginectomy, with urethral lengthening, with, so making sure you understand each of those words that are coming through there, because one, making sure that's what you're wanting, and making sure that you understand what that healing might look like with it. So like I said, so phalloplasty can look a lot of different ways depending on donor site and things like that. Understanding that you don't only just have one wound or one site that you're healing from. So regardless of whichever site you choose, you have another 1 to 2 sites that is going to be healing that you have to be aware of. So it's not just worried about the phallus health, which is very important because you want to make sure that it has blood flow. You want to make sure that the nerves are, connected, bleeding. We don't have any type of fistulas or strictures. And you have another site that is a donor site that has to heal. So that also creates a little bit of, anytime we have extra area or skin open, and that creates a space that we have to be careful with infection and then healing and things like that. So keep that in mind. Phalloplasty can look a ton of different ways. And again, folks don't have to go that far. Now, if you've had meta before and you go into phalloplasty, it does and can make the healing process a little bit better and a little bit faster, in the sense that your body has already been through the initial trauma of surgery. And now you're not doing those internal things, not truly. Now you're kind of just hooking up from the outside some of the phallus, as well as the graft and stuff like that. So it makes it a slight bit easier, right, on your surgeons. And if you've already had meta, and now you're going into fallow, keep that in mind. Yeah, we can get into lipo and sculpting. So that's some of that more masculinizing. Lipo, one, the phallus, depending on where you got your donor site from. So say you did the anterior lateral thigh, that's a pretty large space. Our thighs are typically pretty large, which is why, blood flow is really good and sensation can be really good. However, that's a lot of fat sometimes. And so lipo may be necessary actually of the phallus in order for it to, get to the typical appearing phallus size and girth, and depending on what type of results you're looking for. So lipo and sculpting are things that can not only happen for like weighted areas around the belly and thighs, but also for the phallus too. All right, we've talked about a lot of things on the masculinizing side. Drop whatever questions you have for me. Okay. One question is penile prosthetics. Yes, that is definitely something that can be used. So some folks decide to, some folks don't. So prosthetics can be used for like I said, for the scrotoplasty, right? You can put prosthetics in there in order to create a scrotum and have that. But also for the phallus, if someone wants to have an erection, right, they're going to need a prosthetic because natural erections will not be possible with the phalloplasty. They are possible with a meta. You can have natural erections with meta because there's not any outside tissue or things like that being used as just your anatomy. But with phalloplasty, natural erections aren't possible, so prosthetics are required if that's what we're looking for. And so they can look a lot of different ways. There's pumps. There are just more rigid ones. You definitely want to take a look at what might work best for your lifestyle, but also your desires with it. But that's going to come after you've had the second, third stage of your phalloplasty, right? So penile prosthetics are going to come after probably like 6 months or so after you've had surgery, right? Depending on the staging that you have or your particular surgeon. So keeping that in mind, right? Now, any other questions? Definitely drop them. We'll move over to the male to female, right? So this is the feminizing side. We start with breast augmentation or feminizing augmentation, right? So top surgery. Same concept, right? If we're adding tissue or taking tissue away, we really still want to be aware of postures. We want to be aware of arm stretching and things like that. However, this is where size is determined by whatever you're comfortable with and also your anatomy can handle. So really making sure that it's not going to be, too large to where you're creating other discomforts, but also giving you the size that affirms what you would like. There are different methods again. So there's keyhole method, right? And there's other ways, other different styles to be able to do implants and augmentation, right? Orchidectomy, right, is same thing, similar, right? So that is testicle removal. Now, with an orchidectomy, that is can be really good because if someone is, again, similar to removal of the ovaries, the testosterone level will decrease because the main testosterone creation is coming from those testicles, right? So with that removal, you're able to now not have that battle again with estrogen and testosterone and things like that. So this is typically going to be done if someone is looking to go any further into any type of like bottom surgeries. You're gonna get the testicles removed in that way. Okay, penectomy. These are usually done together. So usually, some folks decide that they do just want to remove the penis, right, and maybe the testicles, and are perfectly okay with their anatomy from that point. They don't want to do a vaginoplasty. They don't want to do a vulvoplasty. They're okay with where their anatomy is from there. And that is an option that people have. Some surgeons do or do not do that. Okay. They still have the ability to say, I'm not comfortable with this. However, making sure that you're very in line with your surgeon on what you do and do not want is super important. But that is removal of the penis. Again, these are words that you will typically see when you are when you're going through your paperwork and just kind of confirming, right? Then we go into vaginoplasty. Vaginoplasty can look just the same as phalloplasty, multiple different ways. They can do penile inversion, right? So that's where the penile tissue, that the skin around the penis is actually a hole is created in between that perineum space, and the penis is inverted. The skin is inverted in order to create that vaginal canal. And so this is where things like tucking can actually be a benefit. So if you have tucked in the past and that skin around the penis has gotten stretched out over that time because it's had a sustained stretch on it, now you have a little bit more tissue that can go in and create that vaginal canal. So some surgeons appreciate that, where now they have a little bit more space to create a deeper vaginal canal depending on the depth that you're looking for. But vaginoplasty, that is an option, right? Penile inversion. Also, though, vulvoplasty, where the vulva is created and there's zero depth vaginal canal, meaning vulva exists, there is the clitoris that has been created from the penile internal tissue, right? And labias, but there is no depth. So that might be for folks who may not want any type of penetration or are okay with vulva presence without actual depth. And then of course there's the non-penile inversion that folks can use for vaginoplasty. So this can be pedicularized intestinal segments. So this is where they take small segments from a donor site, really similar to phalloplasty, right? You take a donor site, you pediculaze it, and then you use that as the internal vaginal canal. Now, some research on it and some surgeons feel how they feel about this, because the idea is that with the donor sites, that there may be just some natural lubrication that might exist. Typically with the vaginal canal, with vaginoplasty, there's not going to be any natural secretion. So you're going to have to use lubricant. You're going to have to douche out the vaginal canal because it's not self-cleaning like, say, anatomical vaginal canal. And you're going to have to make sure you're taking care of the skin, as well as you're going to need to dilate. Dilation is for life, right? If someone is sexually active and they have a partner, then any type of intercourse or intimacy that they have with that partner can be used as their dilation after a certain point. But typically, there's going to be dilation to keep the depth of the vaginal canal. So with the pedicularized donor sites, right? They can use a part of the bowel, they can use a part of the intestine, they can use a part of the rectal sigmoid. It does create another site that needs to heal and things like that we have to be aware of. And again, the research is out, but it depends on the protocol and the procedure and method that your surgeon uses, and if you're comfortable with that, or if that's something that you desire. So being aware of that. And then the facial and neck feminizing. So with that can look a lot of different ways, right? So that can be like the shaving of any types of humps in the forehead or the nose. It can be the smoothing out and more so rounding of the face within the chin area. That can be the shaving down of the Adam's apple or the within the neck. It can also be voice, surgery to help with pitch as well. So that can look a lot of different ways, just to help, again, feminize features that may not be affirming for you. That depends on the provider. You can add implants, right? So if it's, where you're needing or wanting a stronger feature, you can also add that. That's usually going to be more plastic surgery there. Whew. Okay. Listen, I told you we saw this graphic before already, but wow, we went through a lot of stuff around this graphic. I love talking surgeries. I love talking the different types. I love talking like what healing might look like. So that's what we're gonna do next. But again, if you have any questions, please drop them in the chat, or you can message me privately. It's okay, whatever you are comfortable with. Let's get a little bit into wound healing, right? So you've had all these surgeries, not all these surgeries, you've had surgeries, right? You had the skin punctured or removed or whatever. And so now we need to heal, right? big, big, big things, okay, that are going to be important for healing. These are the stages of healing. We're going to talk through them a little bit. But big thing for wound healing, your diet. Your diet is huge, okay? And I'm not talking just like fruits and vegetables, but your body truly needs protein, okay? It needs protein for healing. So when you are, you know, expecting any type of procedure or surgery, making sure that your diet is up to par, that you're getting, you know, the recommended amount of calories in, getting the recommended amount of protein in. Because if you're not getting that, your body needs that fuel in order to heal um, these areas. So you really need to make sure that you are getting enough of that protein in. The other thing is alcohol use. We do not want to drink, okay? Alcohol is not going to be good for your healing. Now, how long after your surgery should you hold off on drinking? I like to be safe and say probably like a month or two. Now, your surgeon's going to have a protocol and they're going to tell you what they feel is appropriate, but you want to make sure that you're allowing your body to heal. We know that alcohol can be a blood thinner, right? And we want these tissues to clot. You need clots. We need blood to clot in order to create healing. And so if you're not able to do that, that can be an issue. The other thing is smoking. Okay, smoking is bad, 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 bad for wound healing. So bad. It actually doesn't allow the tissues to heal properly. And so that's where we get wounds that remain open or that may reopen after closing because nicotine, that's also like vaping, that's also THC or marijuana. We want to kind of stay away from that stuff for, I mean, I like a smoke-free house. However, no judgment here. If smoking is something that you do, you really want to stay away from it prior to your surgery. Some surgeons actually have a protocol that you can't have smoked however long prior to your surgery. And then, of course, afterwards, you don't want to be smoking because you want those wounds and things to heal. At least give it 2 months. Okay? Like, if you truly, absolutely, you know, give it 2 months. All right, let those wounds heal and get past that primary healing phase. Okay. Speaking of which, oops, not subscribers, we're talking about wound healing. Okay. Speaking of which, this is going to be more of a general talk about wound healing because we could go into each specific surgery and how each of them would heal. But realistically, your skin and your body, for the most part, is going to heal across the board in similar ways. We know there are some stages, right? So we start off with bleeding, right? Inflammatory, proliferation, remodeling. That's where we get to skin being back to normal. What does that mean? What do all these words mean, right? So think of like day one, day two. You've had surgery. Your body is still going to bleed. You're going to probably bleed for not nearly the same amount, but there's going to be some bleeding that happens for maybe a couple weeks, honestly. And your tissues are they want to clot, okay? They want to close off that wound. They want to scab over. That is where we normally are at. But in those first 2 days, you know, your tissues may benefit from the smallest, slightest little stretch or stress to them. Okay. What does that look like? That can be like something, if we're talking about any type of chest surgery, we're talking about way down the arm, we're opening and closing the hands, moving the wrists up and down, bending and straightening the elbows, right? We're going a little bit further away from the site, but it still gets a slight stretch on them because the muscles underneath are working a little bit, right? So with that, we want to make sure that we're not doing too much. Like those first early days, we're going to do small things, but they're not going to be that they're not going to be that close to the actual site, right? Now, when we go to a little bit further out, right, we're still in the inflammatory response. So your body is going to respond to the fact that it's been trauma, right? There's been a trauma to the tissues, to the vessels, to the skin, to the muscles, to the organs. And so you're going to have this inflammatory response. Things like fever are going to be common, and you want to make sure that you you want to make sure that you, give me 1 second, please stop. Thank you. You want to make sure that you are allowing for that healing to happen. So these look like, days 12 to 14. Okay. We're having scabs. We should have scabs, right? We should have some initial healing, right? We maybe have some initial stress that is okay. When I say initial, I mean light stress, very, very light stress. So we're going to go a little closer to the body. We're going to do just a little bit of maybe scar massage. Okay, we'll get more into scar massage, but the tissues around. So that's like, if we're talking about the chest, you may go a little bit underneath this chest and make sure that the tissues around that aren't getting too tight, and maybe a little bit above that and making sure they're not getting too tight either. But we're in this inflammatory response stage, so this is why we don't want to do anything that's going to further increase inflammation. Smoking would do that. Drinking would do that. Caffeine would do that. You definitely want to stay away from caffeine while you're in these first couple weeks, maybe up to a month of healing, right? Because we don't want anything that's going to dilate, right? We don't want anything that's going to expand this. We want healing to actually, we want to constrict just a little bit so that things go back to how they're supposed to be. So that's the first 12 to 14 days, right? Now we can benefit from a little bit of stress to them, but not too much. So by day like 15 to 20, we're at the place where typically the risk of wounds opening is decreased. Okay, I'll say that again. So by days like 15 to 20, the wound should be closed. Okay, whether that's sutured, they should be closed, and the risk of them reopening is far less. Obviously, this depends on the depth of the wound. So if we got down to like, if we're superficial layer, right, it's going to be less time than that. If it's deeper layer, it's going to be a little bit more. And we'll talk a little bit about layers too. But all that to say is like, by that 15 to 20 day mark, if wounds are opening up, we are not having proper healing, and we need to go back and call the surgeon or call the nurse, wherever it is or whatever it is. We need to make sure that we're having that addressed, right? When we're talking about wound healing, things that are red and inflamed, after like day 1 or 2, we really want to be like paying attention to any heat on that wound. So anything that was, normal temperature, but now is warm and hot, anything that is oozing. Some of this is normal healing depending on the location. However, if you ever have any question on whether it's normal or not, I always recommend going back to your surgeon and asking them, because you don't know. You just don't know. An infection happens really quick, and we don't want to be dealing with an infected wound, especially if we're talking about around the genital areas or really anywhere else, because infection just throughout the body makes it very hard for healing, and it can increase from there. So just being aware of things like that. And then after like that 20-day mark, right, that 15, 20-day mark, then we start getting into that initial healing phase, which is like that week 6 to 8. All right. After that week 6 to 8, we're pretty good. We got primary healing. All right. We got some proliferation happening. Things are looking good, right? Your body can handle moderate stress. Okay. And I know you're like, but 6 to 8 weeks, that's when my doctor said I go back to doing everything I was doing before. No, not everything. Not at the same intensity. Because realistically, your body's only about 50% of its normal strength. Your tissues from that wound are about 50% of its normal strength. Meaning that the stress and strain that you could have probably handled before, we're not fully there yet. So if you overexert that, we have the risk of really, decreasing proper healing within the wound. So it takes a little bit longer. How long? Well, by week 12. Okay, by week 12, we're at about 80% of your typical strength within that tissue. Right? So we've done our remodeling. We got some, freshly healed skin on top. We're doing good. The scars are starting to fade a little bit, in that first kind of stage of fading. That is when we can really get and start increasing intensity. By 6 to 8, we're increasing slight intensity, but up to 12, we're increasing just a little bit more of that. Okay. So keeping that in mind, by a year out, we're looking at about 90% of, we're looking at about 90% of your tissue strength, which is kind of what we expect. We're not going to get back to 100%. That's not possible. But we're about 90%, which is good. We can work and live with that. Okay. So we're looking at wound healing. We really want to keep that in mind. But again, if there's ever a time where you're like, this just doesn't look right, this doesn't feel right, you definitely want to make sure that you are reaching back out to the surgeon or your nurses to take a picture of it and get some better idea of what's going on. Okay. What questions do you have on wound healing? I cannot stress this enough. Do not smoke. Do not smoke while your wound is healing. Please just don't do it. This is not good for you. This, of course, isn't accounting for any other type of comorbidity. So if you are type 1 or type 2 diabetic, your healing will look a little different. So keeping that in mind, that this is kind of just like general wound healing. Okay. Now let's talk about scar massage. I love scar massage. I love scar massage for so many reasons. Mainly because it can look so different and scars can look so different, right? So if you're someone who might, keloid, your scar is going to look a little different versus someone whose scar maybe, heals flat. So scar massage is one of my favorites. And here we go. Talking about the different layers, right? So on your right, you're going to see just kind of a post-op anatomy of vaginoplasty, right? So we have the bladder, we have the rectum, prostate is still present, okay? There's a clitoris that has been created here. That's a bone. We have labias that have been created here, but this is that neovagina, okay, right? So inversion, and then taking a look, scrotal skin, penile skin, right, urethra. So this is a little bit how that anatomy can look with the surgery. But when you think about this, right, along this line, there are so many scars, internal as well as external, that are present. And so when we start looking at like superficial, right, it's not going to be very deep. That's going to be on the top skin layer. That's important. That's the first step. We're going to start superficial because that's the most comfortable. Okay. Now, it can take around maybe 6 months to heal on those superficial layers. Like, when we talk about getting past that primary healing and like full back to your 90% heal. That's what we mean when we say that. However, on the superficial layer, we want to make sure that we are really taking the skin, and once it's fully healed after those first, 4 to 6 weeks, we can really start applying just the slightest bit of stretch to the tissue. And when I say slight, I mean we're just like maybe just tissue here, right? We just want to even see can it handle pressure, right? Because sitting and things like that, that's a stretch on your tissues. It really is. Using the bathroom, bowel movements, constipation, that is a stretch on your tissue. So we want to make sure that stuff is comfortable, right? Now we go to a deeper layer because in all this area we have muscles. We have muscles that have been cut into, and so we want to make sure that any of that scarring or restrictions that can happen in that layer, we're going into some deeper layers now. They can feel thick. You might feel a knot or like tight. It can be painful in that area. We want to make sure that we're working and using internal methods, sometimes even for improvement there. And again, it may take up to a year to heal, right? We got to a deeper layer. So now we're going to take a little bit longer to get to that full healing. Okay. Now, talk about organs, right? Any of this, inflammation. Anytime your body has to respond to an injury, there's going to be an inflammatory response because that's how we heal. Our body sends all these blastocytes, right? And they say, hey, you need to heal this. But those internal scars are present. This is inside of the body. And so we need to work internally, right, in order to reach those organs. And when I think about it, right, for feminizing, we have the testicles that were removed, we have the penile tissue here that was inverted. Um, we have the prostate and the rectum that had to move out of the way because this space is not typically there, right? That had to be created. And so there may be some, constipation or bladder, concerns that start to happen from that because that's just not a space that was generally already there. And then when we think about organ healing from the side of masculinizing, well, if there's any type of hysterectomy or ovary removal, or even leaving the ovaries, then there is still that healing and scar tissue that happens where that organ used to be. So we have to get really deep into these layers and be aware that scar tissue can form anywhere and healing can be happening anywhere throughout. And it can also go higher or lower. So it can be right, in the pelvis, but it can go up higher into the abdomen where things are trying to find some stability, or where you're holding because you weren't necessarily breathing as much because of pain and things like that. So scar massage, when we look at it, we look at a few layers. So we look at superficial, muscle, and then organ level. Okay. So you always want to make sure. I'm always going to say another disclaimer. What does your surgeon recommend? What do they recommend? What's their protocol? We may listen to it, but thanks for telling us. No, we do want to know what your surgeon recommends and what their protocol is, because that's how they want to see your healing happen. And there are, if they want you to use a specific oil or cream or gel, usually there's going to be a list of items that they want you to purchase prior to surgery. That way that you can have it at, when it's time to use it. But there are the water-based creams, silicone-based gels. But typically we're not needing anything for wound healing. Typically, if it's not going well, or if we find that there's some tissue that is still not healing properly, then there's some other types of um, creams and gels that can be used to help with healing. But the biggest thing though is you want to start slowly and gently. Okay, like when we're doing scar massage, we really want to go, one finger, maybe even, or two fingers, and we're going, pulling it apart just very gently. Okay. And then we'll get into like circles, and, we'll get into just like breaking bread along, right? Those types of movements. But we're starting super slow and gentle. Okay. Now, there may be some initial pain when you start with it. So, because the tissue is breaking up, but that's normal. And we want to back off our intensity from there. So if things are, just a little bit too uncomfortable, we're going to back off and make sure that we're not, going a little too, pushing too hard into that. We want to increase the skin sensitivity and nerve regeneration. Nerve regeneration is huge. This is why I love scar massage. Okay. Because the things that, you're going to come in and tell me, I'm going to say that's really good. So you're gonna be like, it's so itchy. I'm like, that's really good. Oh my goodness, I keep getting these sharp pains. That's a good thing. Or or if it's numb, I'm like, but it's numb in one area and it's kind of in the middle. I'm like, ooh, I like that. So when we talk about nerve regeneration, that's a huge part of healing from any type of surgery, because those nerves have been cut, they've been injured, and so now they're trying to figure out, how do we come back together and give you these signals that something is happening, right? So like what may happen is you get this sharp pain, but it's really quick and it only lasts for like a second. That's because the nerve is trying to regenerate and come back together, and it's sending you this shock, and it's trying to fire and say, is this normal? Am I, is this a danger? And so when those things happen, you want to touch that area, maybe take a big breath, big belly breath, and you want to just kind of confirm to your brain and your body that yes, this is a normal sensation. Yes, we're not under attack. That's okay. You can fire. And so your body will learn that, oh, when I do this, I'm okay to do it and I can feel this, right? Same thing like with this being really itchy. That can be part of it. Sometimes that's healing, but again, those nerves are trying to come back together and figure out what is a normal sensation again. Skin sensitivity, it seems wild that we want to increase your skin sensitivity, but with it being numb, you want to increase your ability to feel just even your hands run across your skin. And then we want to try different textures, right? So we want to try maybe a Q-tip. Then we want to do maybe a washcloth, right? Because our bodies feel, and our skin and nerves feel our clothes. It feels, our watch. It feels all these things on our skin all the time, but it doesn't see it as a threat. What can happen after surgery is, as your body is trying to regenerate and the skin is trying to, come back together in those nerves, now the presence of your shirt being on your body can feel like a threat, and it's just highly uncomfortable. You can't tolerate it, and it's super, super sensitive, right? So we want that sensation to come back in a way that doesn't threaten your body, and it's not hypersensitive, it's not too sensitive, but it's not numb either, right? So we want that normal sensation back. And so that's what scar massage really can help with. And we have to get that at all of the layers, right? We have to start superficial, but we have to go deeper into more layers to get true sensation. Okay, so tell me, what questions do you have on scar massage and things like that? Another thing that with nerve regeneration is, I talked about it, like you might find that one end or maybe the two ends may be more sensitive, but the middle will be numb still. But everything else has, kind of come back, but the middle is still numb. That's actually a good sign, right? Because if things come closer to the body, that means that further out has already done some really good healing, and now there's just one space or one area that we can really focus on. So more towards the middle. Same thing, like, if you have numbness in your hands and fingers, as it moves more closer, say up your arm and closer to the shoulder, that's a good sign. That lets us know that less of the area is affected. And so things like that we want to keep in mind. Okay, let's see. We have a question here on scar widening. So how wide can a scar get, or what can cause scar widening to get a scar to get wider? Okay, so scar widening happens for multiple reasons. So some people's body may just heal that way, and the tension that we put on the tissue as it's healing, as well as like the load. So not just like how well it's able to stretch. Maybe too early on it was getting a stretch. Scar widening is, so typically what you want is that over time the scar may start wide and it should get smaller and smaller, right? It may be present, but we should really kind of narrow it down just a little bit. But it only happens, not only, it can happen from stress. So how much stress did we put on that scar as it was healing in those early stages, in that first kind of primary healing phase, but also how much tension did we put on it? So did the surgeon maybe apply too much tension and it was too tight? And so as it was healing and it started to expand just a little, it kept going and got wider, right? But also the motions, how much movement? So did it get tension on it because instead of keeping the arms down a little bit, we were able, and up here when we had top surgery. So scar widening comes from those things. It's not really a way for us to kind of reverse it, but this is why early on being aware of scar massage and the appropriate times to put tension on things is what we have to pay attention to. Okay. So, which is right, exercise and normal activity. So getting into those kind of things. When we're looking at exercise and normal activity, this is basically like, how do we get back to the things that we like to do safely, comfortably, without the risk of injuring ourselves? That is where we want to be at, right? So the tissues around, they're going to be stiff. You're going to have limited physical activity because you're in the healing phase. So one of my biggest things, breath work, breathe. That's the biggest one, because one, there's typically been anesthesia, And you want to be able to use your breath work because you want to be able to have bowel movements properly, because we don't want constipation. Constipation is not good. The other thing is you want to be able to expand the lungs, because you need to expand the lungs to be able to clear any fluids. Fluids in our lungs is how we get pneumonia. We don't want that. So breathing not only helps with being able to get the proper function of your pelvic floor and your stomach, but it also helps with your other organs too. So that's the first step, is we want to make sure after any type of surgery, we're going to breathe, but breathing is kind of a slight stretch. Like, that's the first thing when we do any type of abdominal surgeries or pelvic surgeries. That big breath into the belly is a stretch on those tissues. So it's going to help keep that flexibility and keep the stiffness gone, right? And depending on where you are with the healing process, that's tissue health, right? And right, we want to make sure the tissue, we're not getting that scar tissue or those adhesions, those really tight spaces, because we're breathing and we're stretching, and we're keeping things mobile. Now, the stretch that you see here is a little bit more intensive that I think is good for initial pre-op. We're not doing that, but it's a really good one once we're at that like 4 weeks, 4 to 6 weeks. Because man, that's going to get a pretty decent stretch. We don't want to go that far, but we want to get into the abdomen and chest and into the hip area. Another one that I really like is to lay on your back and bend your knees and take your legs from side to side. Trunk rotation. Okay, that one's one that we can do pretty early on, depending on the surgery that you've had, because you don't go very far. You get a good movement into the chest and into the hips, and it's a nice stretch, and you can breathe through that process. So stretching, honestly, is going to be so needed with tissue, because when tissues heal, when we have scar tissue that heals, it actually pulls and it gets really tight. And so we don't want to try to just kind of yank it, right? It's like, pulling a rubber band. We don't want to do that, but we do want to stretch it out just a little bit as it is laying down, so that it can heal in a more aligned way versus how it can, which is, all over the place. Okay. So that's why stretching is a huge part, right? And then of course, scar massage. Scar massage. Like, I'm telling you, it's just because it's so important. So here are some examples of how to do a scar massage, right? You can do nice little circles, okay, along the scar. We can do up and down, but we can also, like I said, do up and down. You can do across. And I say you do all of these, right? After this, it's more comfortable, okay? You can kind of grip, but you also can do two hands. Right? That's where we get a little bit of that kind of breaking your bread along, right? Just a little crack, right? You want to make sure what's best for you, though. So anything you can do at home, I love giving people things to do at home. You're going to do scar massage at home because if you're only doing it when you're with your pelvic floor therapist, you're not getting enough of it in. And so you really want to make sure that you're doing it at home, like when you shower, or if you're putting on lotion or a moisturizer. Like, that's a really great time for you to do it also. The heat is really good too, especially like in a shower, because then we have a little bit of, blood flow, increased blood flow to the area. Doing it 3 to 5 minutes, a couple times a day, to help with your healing. Okay. Now, this is where I come in, right? So if you made it here, you made it all the way to this point, thank you so much. And if you know someone, okay, who has had surgery, who has had a procedure, who is on hormone replacement therapy, please, because we can truly help you. Even if that's a resource on finding someone locally, if you're not in the area, or if we feel like it's something we can work on and do virtually, we definitely can help you with that. We really want to make sure that you're understanding and getting the education related to your care and related to affirming care, realistically. So making sure that that's out there has been the biggest thing with this series. So if you know anyone, I am going to drop the link for the nope, just kidding. If you're live, you can get the link. I'll drop the link right now for you. For the replay, the link will come to you in the email. Okay. But what all that to say is, if you are here and you have made it through this series, we highly appreciate you and thank you for the work that you're doing, either for your patients or for the person in your life or for yourself, just being more educated on this. If you need help, here is our contact information. You can follow me on Instagram at Your Pelvic Ally. You can send us an email, info@rosepelvicphysio.com, or you can send us a text or call at our phone number here. Our website is also there. For the next 48 hours. Okay. For the next 48 hours, the a consultation will be free. So that is a link that I will drop for you right now. And if you have some questions that did not get answered or anything like that, that's a good place to go ahead and we can get it answered for you. It is a 15-minute phone consultation where I can either give you resources, I can answer any questions, I can find you a therapist near you. I'm pretty connected in that way. So I appreciate y'all being here again tonight, giving me your time and being here for the people in your life or yourself. And I want you all to have a wonderful night.